I'm Kathleen Heintz, cardiologist at Cooper. I'm here with...
Hi, I'm Dr. Michael Rosenbloom. We're here for our second Facebook Live chat on cardiac issues. Today talking about women's.
Absolutely. So, a couple of things. I'm a clinical cardiologist at Cooper. Been here going on 23 years. See both men and women. I have a special interest in women's cardiac health. Dr. Rosenbloom agreed to talk about cardiac surgery, how it may affect women. We're going to talk about the differences between men and women, what we may share, what might be a little bit different for women. So, Michael, what can you tell us about yourself?
Thank you. Thank you for the introduction. I also want to mention that we'll be taking questions as they come in. Well, I have been a heart surgeon for more than 30 years. Started out in medical school in New York City at NYU, where I did my surgery residency. Then I went to St. Louis, spent 10 years in St. Louis training in cardiac surgery, and then joining the academic faculty at Washington University and Barnes Hospital. I have to say it was an incredible experience to be there. At that time in the 90s, it was one of the leading centers for many things, but in particular for heart surgery. Several operations that we do today commonly actually started there during that time period. And then from there to private practice in South Florida, and I just felt I needed to be back in the Northeast, so I moved to New Jersey to work at Cooper. I was actually recruited here to set up minimally invasive heart surgery, and that has been our philosophy here in our program, to be as minimally invasive as possible. And I've now been here more than 10 years in South Jersey, and I think we've put up a pretty good track record for keeping to that philosophy of being as minimally invasive as possible. Looking forward to our conversation about women's cardiology and cardiac surgery.
So this is our second chat, and we talked a little bit about bypass surgery, valve disease, but what exactly is minimally invasive?
So with respect to heart surgery, minimally invasive involves using specifically a non-sternotomy approach. Well, the typical incision that's been used for the longest time, and still is very commonly used today, for any open heart operation, is divided the breastbone. And people say, are you going to crack my chest? Well, no, we've developed to the point where we have power tools and ways to put it back together. And surprisingly, and I tell this to patients, thankfully I've never had one, but I've made thousands of them, it hurts a lot less than they'd anticipate. In fact, people who had bypass surgery, where we have an incision in the leg to take vein out of their leg and make the incision in the chest, most people complain more about their leg, as you know, than the chest. So that is the traditional approach to heart surgery, is to divide the breastbone. In the 1990s, we began to have tools which enabled, and enabling technologies in general, which enable the performance of surgery, cardiac surgery, through alternate incisions. So as that developed, we now would not do an aortic valve replacement, for example, through a standard central body incision. We would make a much smaller, maybe 2.5 or 3 centimeter incision in the right upper chest, go between the ribs, and perform exactly the same operation. In fact, when I set out to do minimally invasive surgery, that was one of my sort of qualifiers. Am I going to do this or not? Well, I want to make sure that I can do exactly the same operation as well, and not compromise in any way, going through a minimally invasive approach. And so now, that we've done, probably 13 or 1,400 minimally invasive valve operations, I'm very confident that that's the case. So at Cooper, almost all of our aortic valve replacements will be performed through a minimally invasive, non-breastbone splitting incision. Our mitral valve operations are performed coming in and this is especially important in women, in an incision right in the breast fold. Very cosmetic, and a lot of people say, well, I don't really worry about that, but I think it's important. I think being mindful of a cosmetic result is important. And again, we can do exactly the same operation through a small incision. Why make the big incision?
So we're talking a little bit more about women. If you do have questions, please submit them. You can like us on Facebook if you want.
Please do.
So if I talk about women and cardiac disease, really the risk factors are similar for men. Blood pressure, cholesterol, diabetes, smoking, and a family history of early heart disease. they're about the same. Some are more important for women. For instance, diabetes. If a woman's a diabetic, her chances of having a heart attack are way higher. We talked about this earlier. If a woman goes through an early menopause, she's no longer protected by her estrogens until the time of menopause. So she may develop coronary artery disease earlier. The other thing is sometimes women gain more weight after menopause. Well, not necessarily just menopause. Sorry. But after menopause especially. And what we see is they're more likely to develop diabetes because of the weight gain. And we also know the American Heart Association now considers obesity a minor risk factor because it's the weight that contributes to blood pressure, cholesterol, diabetes, all three of them. Okay?
Can I ask you a question that comes to mind in talking about women who go through early spontaneous menopause? Well, first of all, we're talking about around age 40, or in their 40s, I think. Is that the definition of early menopause?
Yeah, so average age of menopause is around 52.
So this would be somebody who's going through menopause in their 40s. And is it something, is the disease process something that could be influenced with hormone replacement, or is it, are there other factors involved?
Yeah. So what we say is women are generally protected by their endogenous estrogens.
But it's the endogenous that's important.
Yeah, but if people, again, it's a little bit, hormones are a little bit controversial on whether to take them after menopause. And actually I think cardiologists, primary care physicians, OBGYNs, we've kind of done a 360. And that is, we used to say, wow, give hormones to everyone. And then, the WHO study came out saying they're pretty harmful. Right. Nobody should get estrogen.
End up doing more harm than good.
Yeah. And then just because we saw a higher incidence maybe of stroke, blood clots, and other things. But then I think that there's been some more contemporary studies that say it may be helpful, and that's a discussion with the OBGYN. The only thing I can say, estrogens taken by a pill form sometimes can decrease some of the weight gain that we see. That's about it. But for the most part, they aren't considered protective like your own natural estrogens. So what happens is it does affect our, probably the vessel. We're kind of, once we lose that estrogen, the vessels may constrict and there may be a little bit more instability in that artery.
Make it stiffer too?
Yep, make it stiffer. And then the other thing is it affects our cholesterol. So our cholesterol goes up, our LDL, which is our bad cholesterol, goes up, our triglycerides go up. So all the bad stuff goes up, and all the good stuff, like the HDL, goes down. So it's then between the ages of 50 and 60 we quickly catch up with men. So what it means is when women present with a heart attack, sometimes they present with more comorbidities. That's our fancy term for meaning other stuff.
Other stuff going on.
Other stuff going on, like high blood pressure, diabetes, things like that. Once you present with, if you do have a heart attack, and let's say you do have some congestive heart failure, a weakened heart muscle, and diabetes, you're much more likely to benefit from bypass as opposed to a stent. So we know most of the studies and the statistics on that, but I think women presenting later with more comorbidities make them more likely to need something like bypass.
Now I know Dr. Heintz is our expert on women's health issues, especially women's heart issues, and I've often heard you talk about the amount of exercise that women should be doing, particularly as they get older. And I don't know how I couldn't come up with that much time in a week, but do you want to say a few words about how much exercise is really?
Yeah, again, it's
advisable?
a moving target, and it depends on whose guidelines you go by. The American Heart Association, they've released 3 or 4 recommendations for women, talking about diet, exercise, food, medication, aspirin, things like that. And yeah, the recommendation is arduous at best. Like they suggest 60 to 90 minutes on most days of the week. And guess what? It's going to be hard to get there for most patients. I think there's other organizations that suggest, look, any kind of exercise you can do is great. Any kind of aerobic exercise you can do is great. That's good conditioning for the heart. Just getting steps in, just cutting out some junk food, just doing minor things, not going necessarily on a diet, but making some minor changes, not to become overweight, not to become obese, are going to make a big difference on whether you need to see him in the operating room. I'm not trying to take away your business. I think you have enough, don't you?
Well, fortunately or unfortunately, we do.
You're happy to take all takers, right?
Absolutely,
Okay.
we do. Talking about bypass surgery in women, I think you had touched on that. Certainly bypass surgery is the most complete form of restoring blood flow in a patient who has coronary artery disease. So what is bypass surgery? Most bypass surgery involves taking either arteries, which are on the inside of our chest wall that we can use as materials, or what we call conduits for restoring blood flow to the heart, or bypasses, or using veins from the leg. And it's open heart surgery, and almost always that operation is performed through a midline incision. And
you know, you got a heart over there.
Yeah.
You want to show us, for instance, if you were going to do a lima to the LAD.
You have the front of the heart.
The what?
I need the front of the heart back.
Oh, he's so particular. He wants.
Well, I want to show the
wall
arteries.
on the heart.
Yeah.
Okay.
So there's a model of the heart, and as you can see on the heart, there are a combination of arteries and veins on the heart. The heart is just a muscle. Unlike any muscle that has to contract, it needs blood supply to deliver oxygen and nutrients to it. The main blood vessel coming out of the heart is the aorta. That's this big red thing here. And then on the surface of the heart, you see the red arteries, which are the ones that get obstructed with plaque. When we do bypass surgery, there's an artery on the inside of the chest wall that is the branch of this artery here. This is the left subclavian artery. And we'll take that down, for lack of a better way of describing it, take it down, harvest it from the inside of the chest wall, and then using microsurgical technique, we can sew that onto this artery and reroute blood supply to this main artery on the front of the heart that we call the left anterior descending.
Hey, how do you know you're not going to need that lima?
It's a good question, but we were created with two arteries that, although they do supply some blood supply to the breastbone, are there and have a particular resistance to plaque formation that, as I say, if you're the creator, you want to give us a solution for coronary disease, that's it. These arteries have they're very durable as bypass conduits. I'll also mention about veins in a moment, but they're much more durable than anything else we have in our body. And in fact, when we look at studies to say how likely is an artery to be open 10 years after surgery, 20 years after surgery, that artery is the single most preferred artery. Very unusual for it to occlude. If it occludes, it's more likely there's something wrong at the level of the heart and developing disease in the heart rather than developing disease in that artery. So
I have to say, out of all the patients I've seen over the past 25 years who had cardiac casts, I rarely see a lima that's gone down or that has blockage.
It's true. In fact, the historical perspective is one of the operations that was done before we had the ability to have the techniques to do bypass surgery was an operation in which we harvested that artery from the inside of the chest wall and implanted it in the heart. And even though we occluded that artery by putting a clip on the end of it and we tunneled it into the heart muscle, it formed collaterals, bringing new blood supply to the heart muscle. So there's something very unique about that artery, and for that reason, we're made with two, and it's like the more the better. If you can construct more bypasses using that particular artery, you give the patient a better chance you give the patient their best chance for a good long-term result.
So how often are you able to use the REMA, the one on the right side?
So there is a small price because we are taking some of the blood supply from the breastbone, and in certain patients, an active smoker, a very obese person where they're going to recover putting a lot of weight bearing on that bone, a poorly controlled diabetic, someone in whom you would think is going to have certain healing problems to begin with, there's a small price to pay. There's a slightly increased risk of delayed healing or infection when we use both arteries. But in a young person, it's an ideal thing to do, because when you have the right candidate for it, we can take the right artery down, in fact, attach that artery to the left artery for inflow, and then almost completely restore blood flow on the left-sided arteries. And it's a very permanent way. In fact, I was just looking at a cardiac cath, the study, the angiography study that we do in a patient that my partner, Dr. Heintz, did, I think 9 or 10 years ago. And he constructed, I want to say 3 or 4 bypasses using both of those arteries. It was a young man, 40-year-old man. Looking at the films today, those arteries are open with complete blood flow to the left side of the heart. So those are very important conduits. As we'll talk about maybe in a minute or two, there are some differences in performing bypass surgery in women and in men.
So he was explaining about the bypasses. We're actually not bypassing the big arteries. We're bypassing, or he is, not me, bypassing these small arteries that actually supply the heart muscle. So you might think we're looking at the big ones, but it's these very small arteries that supply the muscle.
And we're talking about arteries that are between 1 and 2 millimeters in size. That's why I say we need microsurgical techniques in order to make those connections. I should also add that when we use a vein to do a bypass, the vein has to be attached somewhere for inflow. So typically we'll attach it on this big blood vessel here, the aorta, and then the other end gets attached down on one of those arteries.
So if you had to guess, is that about the size of a linguine, a fettuccine?
It's an angel hair pasta.
Angel hair pasta. Okay.
Yeah.
All right, that explains it.
So, bypass surgery, talking about internal mammary arteries, there are certain differences between doing bypass surgery in men and in women. Obviously, a 6'5" man is going to have bigger arteries than a 5'2" woman.
Is that always the case?
Almost always. So what is very straightforward and easy to do in a very large man with a large internal mammary artery, good-sized vein, good-sized target arteries on the heart, can be much more challenging when you do that same operation on a woman and you're dealing with blood vessels that sometimes are right on the limit of whether you can really open them and sew a graft to them and expect that graft to stay open or not. So I would say that when you operate on women, you have probably a slightly greater chance of not being as complete in your restoration of blood flow.
So there's some arteries that when you get in there are going to be too small?
Correct.
Okay.
Now, a lot of times people say, well, doc, how many bypasses are you going to do? Because they want to sit at the pool and say, no, I had 5, I had, 3.
And you're going to say, I'll know when I get in there?
And I can usually give them a rough idea. You're going to have 2 to 4. What? Well, sometimes we get in there and ours is just too small to put a bypass on. And if we do, you say, well, why don't you do it anyway? Well, if we do, it winds up occluding. And then sometimes an artery is too badly calcified. And you really, the plaque is just all throughout the artery. You can't open it. And then sometimes we see an artery that didn't appear on the angiogram, and we say, well, that must be an important blood vessel. Let me put a bypass on it.
So it didn't appear because maybe it's occluded? Maybe
it was occluded higher up and was kept open by collaterals that we just didn't see on the angiogram. So, that's a situation where we would do more bypasses than we thought.
I think you usually end up doing more than you think.
Yeah, probably. Okay. We tend to be, so early on in the history of bypass surgery, we learned something that was very important, and that was the completeness of revascularization. The completeness with which we restore blood flow to the heart is very important in the short term, but really important in the long term. Long-term results are much better if you're more complete in the restoration of blood flow to the heart muscle.
Now, what percentage of the bypasses go down? Do you have any idea?
So, again, getting back to the mammary artery, almost all of those will stay open. Mm-hmm. Vein grafts...
now, when you talk about vein grafts, you're talking about taking it from the leg,
correct.
A vein from the leg, not an artery, but a vein from the leg, and then Where are you attaching it on here?
Right, as I pointed out, we attach one end of the vein to the main artery over here, the aorta, as it comes out of the heart, and the other end gets sewn onto the artery on the heart, the blood vessel on the heart. Now, the veins in our legs are not as consistent and are not as protected from the developing arteriosclerotic disease as the artery that God created us with on the inside of our chest wall. So we could get in there and maybe a patient has varicose veins and the veins are a little bit bigger and we're sewing them onto a small blood vessel. Well, that's not going to be a good long-term result. We could get in and have a vein that's too small or it's thick-walled. You know, the patient's somebody who's been standing on their feet their whole life and, you know, they have what we call venous stasis and thickening of their veins. So the vein is not always a perfect conduit. We have other choices. Sometimes you'll see that people will have the artery from their forearm resected and used for a bypass, but the majority of bypass surgery in the United States is performed with one or two of the internal thoracic arteries and vein from the leg, and the vein can be inconsistent. So the more specific answer to your question is the internal mammary arteries almost always stay open. They have probably a 95% chance of being open at 10 years. Vein grafts, we say there's about a 50-50 chance that they're open at 10 years.
Yeah.
So
let me ask you this. Sometimes my patients, especially my female patients, will say, well, I have varicose veins. Does that mean you can't use the veins in my leg? And mostly I explain to them the varicose veins you have are the superficial ones. What you're going for are the deep ones, right?
Well, yes. I think a lot of people, will judge themselves. They'll look at their legs, they'll see some spider veins, and they'll go, my life is over. I've got spider veins. Really, that is very superficial. There are I guess you would
You're
call
not a superficial kind of guy, you know?
No, not me.
Okay.
Thanks. The next layer of veins is what we call the saphenous vein. It is a more superficial vein. It is not the true deep vein of the leg, but it is an amazing thing that we are created with one vein in each leg that goes from our ankle to our groin. That it's an extra vein that we can harvest without it. Yeah, we can take it out and we can use it, and it's you put it there for us to do bypass surgery with. But seriously, it is a more superficial vein. It doesn't necessarily mean if you have a few spider veins that you've got deep varicosities. There are some people who have varicose veins. It can be one-sided. Doesn't necessarily mean both sides are bad. In situations like that, we use ultrasound before surgery. Sometimes we'll even do it before the patient comes in for surgery to plan the operation better. But we'll use ultrasound, which we always do at the time of the operation, to look at both legs and try to determine which vein is going to be better, which one is the better one to use. I'd also add that in the old days, I hate to say the old days, but in the old days we used to...
We both are there.
Yeah, we've both been there.
Yeah.
In the old days, we used to make an incision and fillet the leg open, for lack of a better word, and take that vein out. And now we use endoscopic technique to take the vein out through a very small incision. And so a patient can have 2 or 3 lengths of vein removed through about a 1.5 inch incision and a couple of stab holes, and it's much easier to get back up on your feet when you don't have that long incision in your leg to recover from, like we used to do in the old days,
All right.
as my kids would say.
We do have a question. I'm not sure I'm that qualified to answer this. It's a question about endogenous estrogens and whether you take replacement therapy. And the question is, why not try FSH to maybe stimulate the hormones?
That's a good
But
question.
I know, but I'm not an OBGYN and I'm not an endocrinologist, so I got to pass that on to my colleagues at some point. I'm not sure that study has been done. I'm not sure that literature's out there, but
I think we would have heard of it if it was.
I'll try to get back to you on that one. I don't have that answer. Now, let's say I'm a female. Let's say I need open heart surgery. Does that mean I'm going to have an incision and it's going to show, every time I wear a blouse or a dress or something like that? Does it have to be the midline incision, and how do you decide?
So to take the last part of your question first is how do we decide it? I think it depends on how much coronary disease a person has. If a person needs 1 or 2 bypasses to the front of their heart, to that anterior descending coronary artery that's different from somebody who needs 4 or 5 bypasses. At this point in time, the standard operation is to make a sternotomy incision, the breastbone dividing incision. Whether it's a man or a woman, I've always tried to keep that incision as low as possible and make it as small as possible to be respectful, but also because I think people will heal better and heal faster if they're not looking at a scar that goes from their neck to their navel. And again, that's how it was done in the old days. But we do try to keep that breastbone splitting incision as small as possible. As I was speaking about, if you need 1 or 2 bypasses in particular, if we need to put the bypass that we're trying to do is to take the internal mammary artery and put it onto that main artery on the front of the heart that we spoke about. We have ways now of doing that using either robotic techniques or minimally invasive techniques. And my 2 partners, Dr. Rosenbloom and Dr. Bowen, have both have an area of expertise in taking down that internal mammary artery, either with the robot or with direct techniques. And there are probably have been more than 100 patients in whom we have done that too. And sometimes that can be done in concert with doing PCI or putting a stent in another artery. So there may be sometimes where a person will come in and we'll find, say, they have a blockage in their right coronary artery, which we might ordinarily want to do a complete operation and do a sternotomy. But, well, lo and behold, that artery is a nice artery for a stent. So either before or after surgery, we will put a stent in that artery and then proceed with taking the artery from the inside of the chest wall through either a robotic approach or a minimally invasive approach, avoiding the breastbone incision, getting a good result, not only restoring blood flow, but also getting a good result cosmetically, which is important.
So we have another question from the audience. If you have any more questions, we'll take them. How many times can a patient have bypass surgery?
So that's a good question, and thanks for asking. Reoperative bypass surgery used to be a lot more common in the era before we had stents. We could go back a second time and put a stent either in a vein graft that developed disease or in an artery whose bypass, there may have been a bypass to that artery, and the bypass now went down, and that artery can be opened and a stent can be placed. And also there are some people in whom we'll go in and we'll do a bypass to, say, 2 or 3 arteries. The other arteries are normal, and 10 years later they come back and now they've got blockage in some other arteries that weren't blocked at the time. So many of those patients can be managed with what we call PCI, or placing a stent. From time to time, we do have situations in which those arteries or veins that have gone down can't be approached, as we say, percutaneously, meaning through a catheter, and we have to go back and do repeat bypass surgery. It used to be a lot more common. I would say that maybe 10 or 15% of our cases that we would do during the course of a year would be a second bypass surgery.
Yeah, I have to say, over the past 25 years, I see less and less repeat bypasses. The other thing is, if you have a nice Lima,
correct,
still to the LAD, it's so hard to open up that chest, isn't it?
Well,
I mean, you don't want to. If
you
can get to the other arteries by not opening the chest and going back in, you're going to.
For sure. And usually, if you think about the fact that we've operated on the patient, usually when they're, say, in their 50s to 70s the first time, now you're also talking about doing a reoperation on an older patient. Yeah. Now, surgeons with a lot of gray hair like me who've done a lot of repeat open heart surgeries for various reasons, we're accustomed to that. I would say the younger generation of surgeons is probably going to see less reoperations, and
so if
is not going to have that same experience.
So if you need a reop,
find somebody with gray hair.
Get an older guy. Okay.
Yeah, I think so. When you choose a surgeon, that's a good question. When you choose a surgeon, you have to have a rapport with that surgeon. You need to have some recommendation, and your cardiologist is usually the one who knows that surgeon and has sent patients to him and knows his work. But you got to have somebody in this day and age with experience, and I think
So,
one thing I just have to tout my guys at Cooper. Our combined experience is really, I've been doing heart surgery more than 30 years. My other two partners have been, one doing heart surgery more than like 27 years and the other one more than 25 years. So we are a very senior group. We have seen a lot of complicated things.
So if I'm coming to interview you, should I ask how many you've done? Should I ask
valid questions.
Should I ask you how many you've done this week? Should I ask you, do you always use the same approach?
Well, excellent questions. Excellent questions. So those are all the things you want to know, and you want to be able to connect with the surgeon as a human being, because I think in medicine in general, the days of the doctor being up here and the patient being down here, it's not the way it is anymore. And I because you send me patients, I really like to interact with the patients, and we're talking about heart surgery. It's not a walk in the park, and
so
they have to feel
do any
comfortable.
questions piss you off? Not really? You're a very patient person. You answer them all?
I try to. It's an emotional time for patients. They, have a lot on their mind. Usually fear. Heart surgery means that they have to take a few months out of their life and put their life on hold. And, everybody comes in with a different set of circumstances. They, do they have a dog to take care of? Are they a caretaker for somebody elderly? Are they, the soccer mom that needs, to be on the go all the time? And, you have to be respectful of that. It's another life and another set of lives, because you're not just dealing with one person when you do heart surgery. It's the whole family is involved. The whole family has to come together to support that patient.
Yeah. So one of the things I talk about with my patients, and I'm sure you do too, is maintenance after heart surgery or after a stent. Sometimes I'll see a patient and I'll see him for the first time, and they'll say, yeah, I had bypass. No, I haven't followed up with anyone. I got it fixed 10 years ago. But it's really not that simple. Some of the medicines that we keep you on every single day help the bypasses stay open.
Right.
One of those medicines is aspirin. Sometimes, almost all the time, if you have a bypass, we keep you on a cholesterol medicine, a statin medication to keep them open. Many times you're going to be on blood pressure medicines. Oftentimes, especially if you have a weakened heart muscle, you may be on medicines, ACE inhibitors or medications like that to help strengthen the heart muscle. So, although Dr. Rosenbloom might do a very good job, it's my job to try to keep those arteries open.
Absolutely.
5, 10, 20 years down the road.
Absolutely. And, we see patients after surgery, and they'll have questions for me about medicines and everything, and I always say, no, asking me to adjust your medicines is like asking Dr. Heintz to come in and tell me where to cut. So,
all right, I don't think you want to do that.
I think, we all have, our roles in this, but patient has a very important role in terms of modifying risk factors. And it really is sometimes heartbreaking to see people who may have had their best opportunity to quit smoking. And, we're all on the rampage about smoking. Quit smoking, adjust their diet, exercise, lose weight, take your medicine, keep your blood pressure under control, and then they just don't do it. And it's really sad, because to go through heart surgery, and to get back to that question, to go through surgery one time is not a lot of fun. To go through it a second time is less fun. And I think the fastest way to have heart surgery again is not to control your risk factors, in particular smoking.
Yeah.
So
I think that's probably our number one. If you have bypass, if you smoke again, you're way more likely to cut off or block those arteries once again. Now, what I usually say to my patients is, if you think about the things that interventional cardiologists do to open up arteries, we used to just have the balloon angioplasty. Sometimes we'll call it the POBA, plain old balloon angioplasty, and that was probably 25, 30 years ago. The restenosis rate on that was pretty high.
Correct.
Next, we have stents, what we call the old bare metal stents, and now the drug-eluting stents. What I usually explain to my patients is our stents, especially the drug-eluting stents, overall, in many cases, stay open, maybe better than a vein graft.
Yeah.
On the other hand, even stents that the interventional cardiologist put in, they're not as good as the Lima. So we haven't taken over your Lima yet.
Well, I think what you're saying is exactly the case, is that we work together, We work together in keeping the patients healthy by getting them to modify the risk factors, by having them on the right medications, by doing surgery when necessary, by doing stents when necessary. And it's more and more, and this is one thing at Cooper that for sure is the case, it's more and more a team approach. In fact, at Cooper, we're in the same department, we're in the Heart Institute. And, we work together, Dr. Heintz and I work together as partners on cases all the time. So it really is a combined approach. It used to be the surgeon was here, he's a surgeon, he's in the Department of Surgery, the cardiologist is in the Department of Medicine, there was no interaction, but we really have a responsibility to be together, working together, and to
we even go to conferences together,
yeah,
right?
Yeah.
We even talk about patients together,
Yeah.
academic conferences, things
Which
like that.
is always a benefit for the patients. It's always good for the patients to have their doctors talking to each other and working together in such a seamless way. And that's something I'm proud of at Cooper, and that was actually something that really attracted me to want to come here.
Yeah, sometimes patients will say, oh, wow, I don't want to go to a teaching hospital. I would say that's where you want to be.
Right.
You would much rather have Dr. Rosenbloom, me, and
Put our heads together.
Yeah, five or 10 other people talking about you rather than one person.
I will say one thing, though, that teaching hospital or not teaching hospital, in heart surgery currently, we're not a teaching institution in heart surgery. So if a patient comes to Cooper for heart surgery, I'm it. I make your incision and I close everything up at the end. I'm there from the beginning to end, and you have my entire attention, and my attention doesn't go anywhere else. I'm not training somebody or anything like that during the procedure. And I think that's an advantage here. I worked in teaching institutions, and I think
you mean where you were training other cardiothoracic surgeons?
Training other cardiothoracic surgeons. And it's important. It's an important responsibility. But I think for some of the real specialty things that we do nowadays, you want to have somebody who's there and who's done it from the beginning to the end.
Okay.
And,
so I want to shift a little bit. Do you have a question? Did someone ask you a question?
I think I want to ask you a question. When did you know you wanted to go into cardiology? Is that a question?
Did somebody really ask that? Mm-hmm. All right. Actually, most people, some people know right away if they want to go into cardiology. I think most people, once they go through medical school, have an interest in internal medicine, cardiology, or some of the other subspecialties. Once they rotate in medicine, and especially in cardiology, that's usually when they make the decision that they want to go into it. Something about cardiology is way more exciting than another subspecialty for someone, and usually that's how we decide. It's probably the area that interests us the most. So I just wanted to move over to maybe talking about mitral valve. And the reason is we do. So,
see how in tune we are?
Yeah. So we may see more mitral valve prolapse in women. Sometimes mitral valve prolapse can lead to mitral regurgitation. There are a lot of other reasons for mitral regurgitation. Sometimes we see it when people have coronary disease, the bypasses. Sometimes we see it when somebody has a weakened heart muscle, has a cardiomyopathy and congestive heart failure. We see worsening mitral regurgitation. Mitral regurgitation, we talk in terms of mitral valve replacement or mitral valve repair. First of all, you can have mitral valve prolapse and nothing ever happens. You never develop a leaky valve and everything's good. Maybe you have a few palpitations and that's it. But there are many times when we see that progress. We always grade mitral regurgitation mild, moderate, severe. When you get in the severe range, what we try to do is take a look at why. Sometimes it's due to the weakened heart muscle, but sometimes it's the intrinsic valve disease. So it used to be that we would replace the mitral valve. A lot of times we're repairing the mitral valve at this point. Well, I'm not, he is. So how do you approach that? So for instance, almost everyone who has mitral valve prolapse with deterioration, are you able to repair most of those? And okay, you know what? Why would you repair it? Because replacement sounds better than repair, even though I know it's not. But if you have a whole new valve, shouldn't that be better than a repair? I know, that's what patients ask you every day. Is that
all the
right?
time. Yeah,
okay.
Great questions.
All right.
But let me start by taking the front off this heart and just demonstrating the mitral valve, if I can get it off. So taking the front off the heart and you see the inside of the heart, most people may or may not know that the heart has two sides. The right side of the heart pumping blood to the lungs, blood coming back from the lungs rich with oxygen into the left side of the heart, the left ventricle. There's a check valve here that when the heart beats keeps the blood from going back into the upper chamber of the left side of the heart and congesting so that the blood isn't really getting out of the lungs if it's leaking. So when this valve leaks, we call that mitral regurgitation. A leaking mitral valve is, as you said, common. It can have a number of different causes. The mitral valve prolapse syndrome, which is more common in women. That's part of the spectrum of pathology that takes place in the mitral valve, which has to do with degeneration of the actual tissue of the valve. It can be due to a deficiency of the fibroelastic tissue, the stuff that makes the valve leaflets stretchy.
Like a patient with Marfan or a patient with
or actually,
lupus.
yeah, that's the most extreme case where we have what we used to call Barlow's valve, where the valve is billowing. Or it could be just a more minor form of that deficiency in which some of these supporting structures that we call the chordae tendineae, we call them cords, can rupture.
Or stiffen up.
Or stiffen up. And the valve comes together like this, and if one of those cords will rupture, it might do this, and so you're getting leakage across.
And it leaks up into the upper chambers, and it can back up into the lungs.
That's exactly right. And, well, I know you know. And that's why people will have shortness of breath when they, as one of the main symptoms when they have a leaking mitral valve. You asked the important question, why don't I just replace the valve? Well, the way I like to answer that to patients when we talk about mitral valve surgery is there is nothing that I can take out of a jar that is better than your own heart valve. Your own heart valve is more resistant to infection. Your own heart valve is more resistant to blood clots. It has better long-term function than anything I can take out of a jar and put in. These days, if we have to replace a mitral valve, we have the choices fall into two basic categories. One is a tissue valve, either derived from cow tissue, not actual cow's heart valve, but derived from cow tissue and fabricated into a heart valve. And that's probably the most common valve that we use in 2018. And everybody's heard of pig valves, which is the other kind of tissue valve, and that actually is the pig's heart valve.
What percentage are bovine, what percentage are pig?
Well, surgeon preference.
Mm-hmm.
For various reasons, somebody may want to use a cow-derived valve. Since the early 1990s, the long-term data has shown that the cow-derived valves are very durable, maybe more durable than the pig valves, and they also have superior blood flow characteristics. So, since the early 1990s, when we want to use a tissue valve, we would use a cow-derived valve as opposed to a pig valve. But, like a pair of shoes, they don't last forever. So these valves will deteriorate. They are basically made out of leather. They can deteriorate by stiffening, in which case you're creating a blockage across that valve, or they can deteriorate by tearing, in which case the valve will leak. The alternative valve is a mechanical heart valve, and that it's made out of a substance called pyrolytic carbon, fancy word for graphite.
Mm-hmm.
It's not actual metal, but it's a metallic-looking valve. They make bicycle frames out of carbon, and it's a highly polished ceramic, fabricated also into a heart valve. Long-term, excellent blood flow characteristics, a much more permanent valve, but it comes with a price, and that is the need to take a blood thinner, a pill called Coumadin, that you'd have to take every day for the rest of your life under a doctor's direction, getting blood tests. Most people don't want to be on Coumadin. I've had one patient today tell me, that's rat poison. Yeah, it's rat poison.
It's the same thing we use for rat poison, it's true.
Yeah.
But, the other disadvantage of that, there's significant dietary restrictions throughout life with that. Anything that has vitamin K in it, it'll affect that. Oftentimes you have to go for a blood test at least once a month, sometimes up to once a week. So
it's a little more complicated.
What about the durability on the bioprosthetics?
So our bioprosthetic valves are very durable, but not permanent. So generally, if a person is 65 or older and they get a tissue valve, the chance of that valve deteriorating and being a problem in their lifetime is probably somewhere in the 5 to 10% range. So 60 to 65 is our usual starting point for whether we're going to put in a tissue valve. Certainly if somebody's in their early 50s and younger, we would be recommending a mechanical heart valve, because I don't know about other people, but personally I don't want to take my operation, I don't want to have another operation. I certainly don't want to go through the thinking that there's another operation in the future. So if I'm a young person, I want a mechanical valve.
Now,
Most people want a mechanical valve.
All right, so let's say you're a woman, and let's say...
So that's important.
Let's say you need surgery,
Right.
and let's say you're still premenopausal, let's say you're still thinking about becoming pregnant. Would you suggest, which valve would you go with?
So that's for this actual form, that's the real important question. So first of all, I go back to repair. Mitral valve repair is clearly better for a leaking mitral valve. Of the causes of mitral regurgitation, leaking mitral valve in young women, many of them can be repaired, but there are some times when they can't be repaired. And if one of those situations is the case, there's a very important discussion the patient has to have with the patient and their family. Sometimes their husband has to be involved, and that is, if we were to put a mechanical valve, which would be what you would think we would want to put in a 25-year-old woman, if we're going to put in a mechanical valve, that patient's going to need to be on Coumadin for the rest of their life. Well, that's not necessarily compatible with becoming pregnant and having children. So, it's...
So oftentimes what'll happen, if you do have to put in a mechanical valve, let's say it's a young person, during pregnancy, the high-risk OBGYNs oftentimes will switch the patient over to the injectable Lovenox.
Which is really not FDA approved for a mechanical valve, but it's the only choice.
Right. But there are some other studies that say you can, the time for problems with warfarin are during the first trimester. And there are some physicians who continue warfarin until around the time of expected delivery and then switch over. But again, this is off-label use.
Right.
The Lovenox or the low molecular weight heparin would be the other name for that.
So I think the best thing in that situation is, if the patient wants to go through childbirth, is that we put in a tissue valve. And typically with tissue valves, some people will anticoagulate for a few months, some will just go right to aspirin. But we put in a tissue valve, and the patient has to have the understanding that something's going to need to be done when that tissue valve deteriorates. Now, these days, that doesn't necessarily mean going back in right away for a valve replacement. Transcatheter valve replacement has developed commercially, and since 2012, and even before that, I hate to use the word experimentally, but under research protocols. But we have the ability to deliver a valve into a deteriorated tissue valve through a catheter.
Yeah, so let's say someone gets the bioprosthetic or the tissue valve. We can expect for that to last 15, and some are going even out to 20 years at this point.
Well, that's right? In an older patient. Valves tend to deteriorate, the tissue valves tend to deteriorate faster in younger patients. So, we'll put in, say, a 50-year-old man wants a tissue valve. I'm going to tell him he's got about 10 or 12 years.
Gotcha.
A younger woman, to be honest, I'm going to tell her somewhere you may have 8 years to 10 years, something along those lines.
Okay.
And during that time, she can have children, not have to worry about being on blood thinner. If the valve deteriorates, we can put in a transcatheter valve into that valve, and sometimes even a second time. So we can get her into her middle age with tissue valves, not having to be on blood thinner. And then at that point in time, if something needs to be done, they can decide whether they want to have a mechanical valve at that point in time or just a reoperation and start fresh with a new tissue valve. And technology is always advancing. I anticipate 10 years from now, we're going to have things that we don't know are here now.
Yeah. So we have another question, and that is, this is somebody who had rheumatic mitral valve disease. Actually, we see, probably in the U.S., we see more mitral valve prolapse with deterioration of valves. We don't see that much rheumatic heart disease in the U.S. because usually they happen with infections when they're younger. And then what happens is it affects the valve over time and it makes it stiffer and doesn't function very well. Nonetheless, usually that happens in childhood, and we see slow deterioration of the valve and, culminating in mitral regurgitation and sometimes stiffness of the valve. If you had a mitral valve replacement in 2017, chances are that valve has been deteriorating for years, 25 years sometimes,
yep.
20, 25 years, since you were a child, most likely.
And as valves deteriorate, we see this all the time. If you go home and you go up to your water faucet, and I always like to give this demonstration to patients. You go to your water faucet and you start to shut the water faucet. That first half turn doesn't even slow the water down. It starts slowing down between half and the quarter turn, and then the water really shuts off in that last quarter of a turn. So you don't really feel the blockage of the valve until it gets to that last quarter of a turn, that last narrowing, for lack of a better word.
So we have another question, and that is, how do you know if you actually need bypass or if you need a stent? So I think the first thing we would think about is if you're having any kind of a symptom. If you have a persistent chest pressure that doesn't go away, if you have a persistent shortness of breath that doesn't go away, if there's something that, a persistent symptom, even, we talked about this earlier, women do present atypically sometimes, not with the typical symptoms. Still, the most common presentation for women is the typical chest pressure, but they often have additional symptoms such as some GI upset, maybe a pain that goes around to the back or to the shoulders. They may just feel sick to their stomach every single morning or when they exert themselves. And this is something to get checked out. Now, I'm not saying everyone who has a little bit of stomach upset after they, eat a big plate of spaghetti and meatballs and start to get agita should go. No. But if there's something that...
Told them to change their diet.
All right. Yeah, but if there's something that you're worried about and you do have some risk factors, let's say diabetes or high cholesterol, it's probably worth it to talk to your doctor about a stress test or a referral to cardiology to get it checked out, because your insurance probably won't approve it without a consultation to cardiology.
Is there a certain age at which a woman should consider getting a stress test, no matter what her risk factors or?
You know what? I think for most women, if they have any kind of symptom, a treadmill stress test is reasonable. I think certainly after menopause, especially as we see cholesterol shift a little bit, especially if there is any weight gain, it may be reasonable to think about a stress test. Especially if you have a strong family history, maybe of premature coronary artery disease, or let's say you have sudden cardiac death in your family, something that is an extraordinary risk factor or something that puts you at higher risk, I would think about it. And I might encourage somebody to go to see a cardiologist sooner rather than later, especially if you have a strong family history. Now, I think we're going to have to be wrapping up here in a couple of minutes. Okay. So, do you have any last thoughts that you wanted to bring up as we close out here?
I think we had talked just briefly about mitral valve surgery and just mitral valve surgery at Cooper. I'd just like to, comment that mitral valve repair.
It's your passion.
It's my passion.
We know that.
It's even my MR is my initials. So.
I think you told me that the first time I met you. No, not about the initials. About the.
It's
your
I've
passion.
been pretty passionate about mitral valve repair since I was training. It's something I've always had an affinity for. I like to do. Heart surgery is a very unique specialty. It is. Many surgeries aren't so reconstructive in so many different ways. A lot of surgery, you're just going to take something out. There's a tumor, you're going to take it out. And, maybe plastic surgery is reconstructive, but heart surgery and what attracted me to heart surgery, it's such a dynamically amazing thing that you're working on heart, the heart beats, you stop it, and there isn't a day that goes by where I do heart surgery where I don't realize how amazing it is that we can do this. And it truly is, but I'm very passionate about mitral repair and actually minimally invasive surgery, as I started to talk about before. when we came here, they recruited me here to set up a minimally invasive program, and I think we've done that. And that philosophy of being minimally invasive has been our pervasive philosophy in aortic valve surgery, in mitral valve surgery, in coronary bypass surgery, and even in the non-cardiac thoracic surgery that we do. And it's a very gratifying thing to do an operation through a small incision, see the patient recover, and realize that 15 years ago what you just did was not possible. And that's another amazing thing about heart surgery. It's a very young specialty. When I started out as a heart surgeon, I had the ability to meet everyone who ever did heart surgery. So heart disease in general and taking care of the heart and heart surgery are truly amazing things that we've been given the ability to do.
So thanks for joining us today.
Thank you.
Dr. Rosenbloom and I,
Yeah.
we're available if you have additional questions. I thank you for joining us, and then we will see you next time.
Yeah, hopefully this is our second version of our Facebook videos, and we hope that we get to see you again for our next one. Thank you for the questions that you've sent in, and look forward to the next time.
Okay, bye.